Hello, psychology students. Professor Zeeb here, and welcome to our lecture on Chapter 10, which deals with sexual dysfunctions, paraphilic disorders, and gender dysphoria. So I'm going to warn you as we get into this lecture, we're going to talk about a lot of touchy, sensitive stuff. We're going to get very adult in this chapter because obviously we're talking about sex, but I know you all can handle it and it's going to be great. So let's get into Chapter 10 in our lecture here. All right, so we're going to talk about three types of sexual behavior that are abnormal. Sometimes it's just easier to start with discussing what's considered to be abnormal in our class here. So let's take a look. We have something called gender dysphoria, which we're going to talk about, which is basically psychological dissatisfaction with one's biological sex. So it's more of like an identity problem than an actual disorder where they're not happy with their biological sex. We have sexual dysfunction, which is the difficulty functioning adequately while having sex. For example, not being able to obtain an orgasm would be an example of that. And then finally, paraphilia, which is where the person experiences sexual arousal in the context of inappropriate objects or people. So, for example, they may have a fetish, like a shoe fetish, and they can only get aroused if that's involved in the sexual picture. All right, so let's take a look at some sexual research here. So here's what we know. So to understand, how we get this data, it's determined by doing surveys with people, which obviously is self-report from randomly sampled populations. So it's been discovered that vaginal intercourse is obviously a nearly universal experience, is what we're finding. But the survey we're going to look at specifically was done with 18 to 44 years of age individuals. So they found that 92.3% of women and 95.1% of men said they were heterosexual or straight. 1.3% of women and 1.9% of men reported that they were homosexual, gay, or lesbian. 5.5% of women, 2.2% of men reported that they were bisexual. 0.9% of women and 1% of men said they didn't know or chose not to give an answer based on that survey. By the way, this was a sexual survey conducted by Indiana University Bloomington, as well as the National Survey of Family Growth by Centers of Disease and Control and Prevention. Among those who experienced heterosexual behavior, the vast majority, uh, so it was a mass majority reported that they had vaginal intercourse. Slightly more women than men reported that. And then when it comes to oral sex, a little bit less common, but once again, slightly more. Well, in this case, it was slightly more men who admitted that. In terms of anal sex, the numbers are definitely lower, probably about half the percentage. So, for example, women, 86.2% of women said they'd had oral sex before, whereas anal sex, it was 35.9%. And that, we see a significant similar finding with men. That's probably due to connection to things like AIDS is often associated with that, not entirely, obviously, but that has to factor into that. More women than men reported experiencing same sexual behavior in their lifetime. It was 17.4% for men, 6.2% for women. I'm sorry, excuse me. For women, it was 17.4, men, it was 6.2, excuse me. Feelings of attraction only to the opposite sex were more common for men, 92.1% compared with women, 81%. All right, now we're going to look at some other research in regard to the elderly. Okay, so research shows that the elderly report an active sex life, contrary to popular opinion, and that can even continue past 80 for some people. Generally, men age 40 to 80 report more satisfaction with their sex life compared to women. So older men often report more satisfaction compared to women. So, for example, a study found that 38.5% of men and 16.7% of women between the ages of 75 and 85 were still sexually active. But remember, more men in the study reported that they were satisfied with how things were going. Okay, so next we turn to reasons for decrease in sexual activity for the most part. So remember, we're referring to more the elderly population, even though we know that a lot of elderly people are still having sex and are relatively happy with how things are going, the frequency of sexual encounters definitely declines with age. So one of those reasons is decreases in general mobility, which obviously is related to developmental concerns. Disease plays a factor into this. So good health and mental health too is often connected to sexual well-being. So if a disease is holding you back, then that would change things. Medication will play a part into this as well because it reduces arousal or can reduce arousal in certain circumstances. And then a decrease in intensity of various vasocongestive responses, meaning the swelling of tissue by blood. So obviously things like erectile disorder, dysfunction would factor into that. Next, we're going to look at some gender differences in sex based on research. So when it comes to males in our research, males report a more permissive attitude about premarital sex compared to women. However, that gap has been shrinking and does decrease with time. Men report masturbating more and are more likely to admit that compared to women. In fact, some studies show that men masturbate 2.5 times greater compared to women. Males also report more partners and frequency of sexual intercourse compared to women. Males also focus on the arousal aspects more in sex compared to females, meaning like physical gratification is kind of what I mean by that. Men are also more specific about what they want in the bedroom as well compared to women. The studies in terms of females show that females tend to focus on love and intimacy more compared to males. Not that men don't, but if we compared them, we would find differences in that. Okay, continuing on. No gender differences exist for the following based on research. Attitudes about homosexuality in terms of accepting it. Attitudes about masturbation, once again, in terms of accepting it. The importance of sexual satisfaction. In other words, it seems to be important to both when we research this. We do see a difference in sexual self schemas compared to men and women. So the core beliefs about sexual aspects of oneself is kind of what we're referring to. So just in general, we're going to find that females report that passion and romance are more integral part of sexuality, but may feel embarrassed, conservative, or more self-conscious about expressing that. Men often report things like aggression, independence, and feeling of power in connection to the sexual self. So that leads us to our four themes in human sexuality, which was brought forth by Peplau back in 2003. So men show more sexual desire and arousal compared to women. Women emphasize committed relationships more than men do. Men's sexual self-concept, as we said before, is often characterized by power, independence, and aggression, more so compared to females. We're also finding that women's sexual beliefs are more flexible compared to men, meaning they're more shaped by culture, the situation, and social factors. So, for example, women are more likely to change their sexual orientation compared to men. They're more willing to adapt to the preferences of a new partner compared to men are, and are more variable in frequency of sex. For example, if a partner leaves, as an example. Okay, so we're going to switch gears and move on from this point. Keep in mind, we looked at this research, which mainly centers around more Western type sexual practices. But keep in mind, there's going to be a lot of cultural differences in terms of how sex is expressed and experienced. So please read the textbook because they give some great examples of this and demonstrate that. All right, but we're going to move on to something we call sexual dysphoria. Okay, so as an example of this, we're going to look at a really famous case of this. Okay, and so once again, this is Chaz Bono. Keep in mind, this was formerly called gender identity disorder, but they've since changed it in the DSM to gender dysphoria. So this was originally the daughter of Cher and Sonny Bono. I don't know if you guys even know who that is anymore, but the famous singers from the past. And so their daughter here, you can see, first came out as a lesbian and then went through the process of changing their sex. So later through sexual reassignment surgery was changed. So just as an example of gender dysphoria here. Okay, so let's look at our description of gender dysphoria, also referred to as transsexualism. So you may have heard that, or transgender. Physical biological gender is inconsistent with his or her sense of identity as a male or female. So, for example, it's often described or can be described as a female trapped in a man's body. Typically, they're male, 3 times more likely to be male, but is considered to be overall rare when we compare it to other disorders listed in the DSM. So, for example, it occurs in far less than 1% of the population, which is considered to be rare. A lot of people confuse this with being a transvestite. So this is different from what we call transvestite fetishism. So this is where the person can become aroused by wearing clothes associated with the opposite sex. However, the primary goal of transsexualism is to live their life openly in a manner consistent with the opposite gender. So the major difference there is with a transvestite, it's typically more about sexual gratification, where this is more of an identity sort of thing where they want to become this other biological sex. It's also different from what we call hermaphrodites, which are basically, similar to intersexed individuals, formerly we called them, where they were born with ambiguous genitalia, where it's not quite clear if they're male or female. Okay. So it's going to be different than that, technically different than that. It's also independent of sexual arousal patterns. Okay, so the DSM states that because sometimes their sexual preference can change through the procedure, or it could remain the same, or they could become bisexual. In other words, there's a lot of variation. Excuse me, not enough to see a clear pattern. So it's thought to be independent of their actual sexual arousal pattern. Okay, so they may show a developmental pattern called sorry guys, I can't see my slide here. Autogenophilia. Gender dysphoria began with a strong, specific sexual attraction to a fantasy of oneself as female. So it's not that they were effeminate boys as children. They're just showing a gender dysphoria began with a strong specific sexual attraction to a fantasy of oneself as female. For example, they may be possibly aroused while cross-dressing or fantasizing, and then eventually they decide that they want to become a woman, if we're talking about a biological male in this particular case. This is very controversial idea, but can be supported by research. But it also shows that gender dysphoria could be developmental in nature in terms of gender dysphoria. All right, let's take a look at some of the causes of gender dysphoria. There are no known biological contributions to the development of gender dysphoria. However, some have theorized that there may be some kind of predisposition genetically. And so we think that in the future that will probably be revealed, but at this point we don't have definite evidence of that. So that's really been circling in the theoretical perspectives of this one. Some people believe there's high levels of certain hormones at critical periods of development. For example, maybe we have a female fetus in the womb that's exposed to high levels of testosterone, which then masculinizes the female fetus, or vice versa. So that has been theorized that potentially could happen. However, we don't have complete supporting evidence for that yet. There is some evidence that gender identity firms up at 18 months to 3 years of age and then possibly becomes fixed after that. May be learned at an early age. So this could be due to things like parental encouragement or discouragement, depending on the case. We also see evidence of gender nonconformity. So being, brought up or around gender nonconforming attitudes or behaviors may actually factor into this and influence it. Okay, so how do we treat gender dysphoria? There are definite current guidelines recommended for using the least intrusive steps first. In other words, using things like therapy, education, before going to the irreversible steps, meaning like surgery. So it's often encouraged that they go through the education to make sure psychologically they're prepared for this and are willing to do this or really want to do this before they take irreversible steps. So treatment is sex reassignment surgery or can be. Remember, this is irreversible. So to qualify for this, they have to live in the opposite sex role for 1 to 2 years. They also have to demonstrate that they're stable psychologically, financially, and socially. In other words, it's just showing that they're in a good place going into this. They're making a good decision in the transformation. So, with our male to female surgery, they're given hormones to produce something called gynecomastia. And so that helps to develop breasts. Their facial hair could be removed by electrolysis. Their genitals could be removed, and then a vagina could be constructed if the person is satisfied. So, with female to male surgery, they would construct an artificial penis using plastic surgery. This is often done with muscle and skin grafts. Their breasts can be surgically removed. Okay, so that's kind of what the surgery would require. Next, we're going to look at the estimates of satisfaction. So, is the person happy with going through this procedure? The problem with this data, however, is before we go through it, is that a lot of these individuals, for various reasons, were not available for follow-up data. They weren't available to be interviewed later, or they couldn't get data from these people for some reason. But if we look at the data that they did collect, they found that the rates vary from 75 to 100% reporting satisfaction with the surgery and or adjustment. In general, female to male tend to adjust better on average, if we look at what the research is showing. And then approximately 1 to 7% regret the surgery afterwards. Keep in mind that it can often be associated with alcohol problems, psychosis, and poor family support. So there's a lot of other additional problems that sort of seem to correlate with this one at times. So, in fact, we do have a small percentage that actually attempt suicide after the adjustment. So, we're very concerned about that. So, even though it's a slight chance of suicide, it's about 2%, that's still considered to be higher than the general population. So, we're concerned about that. Okay, psychosocial treatment, which is often done before the surgery. So, attempt to modify their thinking and behaviors to be more consistent with one's biological sex. So, this could include therapy and education to sort of modify those behaviors to make sure that they're consistent and this is what the person really wants. Once again, it kind of depends on the situation. Okay, so next we're going to switch gears and go to sexual dysfunctions. So in this case, it's more a problem with actually having sex rather than, like an identity, a problem that we just talked about with gender dysphoria. Keep in mind, despite these, people still report that they're very satisfied with their sexual life. So a lot of these are pretty common, we're going to find. But regardless that this is happening, a lot of people still report that they're satisfied. Okay, so let's get into these. So first, we're going to examine the stages of the human sexual response cycle. It's important to kind of understand as we go through these. We're just going to quickly look at this next graphic here that goes through the different stages. So we have the desire phase where the urges occur in response to sexual cues or fantasies. We then go into an arousal stage where we would see increased blood flow, leading to an erection or lubrication, for example, erect nipples, for example. Then if things continue, we go into the plateau phase, which is the brief period occurring before orgasm. Then it reaches an orgasm phase. Remember, we're saying this is a normal cycle where the males feel point of no return basically with an ejaculation. Females sometimes feel contractions of the walls of the lower third of the vagina. And then once orgasm occurs, we go into a resolution phase where arousal levels basically go back to normal to a resting state. So that would be considered, the stages of sexuality, if you would, and a more normal cycle of what we would expect in that experience. All right, so sexual dysfunctions can be lifelong. In other words, they may be present for the person's entire lifetime. They can be acquired, so maybe suddenly they're interrupting their normal sexual pattern. They can be generalized, meaning they can be present in every encounter. They could be situational, where they're present only with certain partners or at certain times, for example, or certain situations, meaning due to psychological factors with or without a general medical condition. In other words, they could occur with medical conditions or without. So it may be a hormonal problem, a vascular problem, for example, connected to a medical condition. Okay, and so next we go to the sexual desire disorders. So remember, we said that's one of the phases of the human sexuality stages or process. So in this case, we're talking more the desire part of that. So we're going to look at first the hypoactive sexual desire disorder. So the person shows little or no interest in any type of sexual activity. In fact, 50% of patients who come to sexuality clinics for help report this. Shows it's pretty common. Most of them are women. For example, 22% of women and 5% of men suffer from this. With men, we're going to find it actually increases with age. And for women, it actually decreases with age. So it's kind of interesting. The prevalence is different for the genders there. Patients rarely have sexual fantasies or masturbate and attempt intercourse once a month or less. So that's pretty common of this problem. It often causes distress and interpersonal difficulties. All right, next we go to sexual arousal disorders. So the difference here, it's happening during the arousal phase. So they still have desire and the urge to have sex, but in terms of performance, something is hindering that. This is referred to as erectile disorder in men, erectile dysfunction, where the man is having problems getting or maintaining an erection. For women, it's female sexual interest arousal disorder. So this could be problems with getting or maintaining lubrication during sex. The problem is that it's difficult for the person to become sexually aroused. So once again, they still have desires and urges and fantasies, but being able to perform can be a problem. We used to describe this as being frigid, which is an outdated term, and quite frankly, derogatory. So once again, imprecise label that we don't use to identify with this anymore. Males typically feel more impaired by this than females, which is pretty obvious why, because it's hard to perform if you can't become aroused, where women could obviously use artificial lubrication and still have intercourse. So even though it does affect both genders, men often report this more of a problem. Okay, so 5% of men, if we look at ages 18 to 59, actually experience this. The problem does increase with age, especially after age 60. So globally, if we look at this, from a global perspective, 60% of men over 60 experience this. So probably one of the most common problems for which men seek help in sexual clinics. Prevalence in females is hard to estimate. Most women do not report an absence of arousal as a problem. So our numbers are more about 14% approximately experience this in their lifetime. Remember, because this can often overlap with desire, arousal, and an actual orgasm, it's hard to actually estimate the true numbers of this problem. Okay, so next we go to orgasm disorders. So once again, talking about a different stage in the cycle. It can be, things like inappropriate timing of the orgasm or not experiencing, the inability to experience an orgasm at all. So the first one is inhibited orgasm. Pretty self-explanatory. Inability to achieve an orgasm despite adequate sexual desire and arousal. This seems to be pretty common in women, also known as female orgasmic disorder, but seems to be more rare in men. This is one of our most common complaints of women seeking therapy. About 25% of women report this problem, although the data varies. The research basically estimates only about 20% of all women report having regular orgasms during intercourse. So due to this reason, for a woman to be diagnosed with inhibited orgasm, She must indicate that the orgasm never occurs or almost never occurs in the survey. Keep in mind that this also affects men too, but differently. So it could be a delayed ejaculation in men, where the ejaculation is delayed or with great difficulty. This is seldom sought for treatment, even though it does show up. So we think about 8% of men have delayed or not at all ejaculation, and they just find a way to accommodate for that somehow. There's also retrograde ejaculation, and so in this case, the seminal fluid is flowing backwards rather than forwards. This is usually due to the effects of medications or medical conditions, for example, Parkinson's, diabetes, just as a couple examples that can result in this one. Premature ejaculation, which seems to be pretty common with males. So the ejaculation occurs well before the man or partner wishes it to. So the frequency of this one is going to be pretty high. One of the most frequent male sexual problems of all time. So 21% of men meet the criteria for this, and 60% of men who seek treatment for sexual problems report this one. The problem with this is that it's difficult to define exactly what premature is. In fact, the adequate length of time varies from couple to couple and person to person. So in this case, we're saying they usually climax within 1 to 2 minutes after penetration, where if we averaged it out, it's about 7 to 10 minutes for most people. The point is that it's considered to be earlier than what you would expect, and the person's not happy with the length of that. So thus, it may be more important to look at the perception of lack of control as a psychological determinant of this. In other words, what do they perceive to be not enough time or what's actually early for that person? Research is also showing that it usually occurs in young men who are inexperienced and have less education about sex. In other words, they've not been around the block as many times. They haven't found ways to make it last longer, if you would. So it could be that they're just inexperienced for some reason, and they're will get there eventually down the road. So the research does confirm that it seems to decline with age. Okay, sexual pain disorders. So we'll kind of conclude with this one. So as the name implies, it's involving marked pain during intercourse. It may involve things like panic attacks, anxiety before sex, which, leads the person to not wanting to have it. Research shows that about 7% of women in North America suffer from this. Typically, they're younger women and less educated women. Okay, so the first one is genitopelvic pain penetration disorder. So the DSM-5 has combined these. So the person is experiencing pain during intercourse, or it could be that they're having anxiety in attempted intercourse. So in this case, the sexual desire is still there, but the pain may actually disrupt sex. Diagnosed if no medical reasons for pain can be found. So in other words, they don't have a urinary tract infection or some kind of tear. It's thought to be more psychological in nature. And it seems to be pretty rare in the sex clinic. So not a lot of people come to therapy for this one. Vaginismus, which is a form of the previous disorder, obviously a more female, a female condition. And so this is where the pelvic muscles in the outer third of the vagina undergo involuntary spasms when intercourse is attempted. So for example, this person may experience this when they're putting a tampon in, or maybe they're at the gynecologist and this starts happening. But usually I think in this case we're saying it's a sexual situation, but doesn't have to be. The sensations are pretty hardcore, so they include ripping, burning, tearing sensations during an attempted intercourse. And then approximately 6% of women have this in the United States, according to research. Okay, so that will conclude our lecture. So please move on to the next step in the class to learn how a lot of these are caused and treated. So make sure you read that section and enjoy the class.